The HOP2 payment reform model includes 3 types of payment: facility payment for treatment of the 6 qualifying conditions in-house at the facility, and 2 practitioner payments, one for on-site assessment of an eligible beneficiary for one of the 6 qualifying conditions, and the second for care coordination and caregiver engagement. The HOP2 payment reform model is limited to eligible practitioners. Eligible practitioners have carried an average of at least 7 long-stay fee-for-service Medicare beneficiaries in each affiliated participating facility over the most recent 6 months. They have all licensure and certification in good standing. They do not have any sanctions or indictments imposed in the last 3 years relating to fraudulent or abusive billing practices, are not excluded from participating in the Medicare or Medicaid programs, and have signed and returned a letter of intent to participate. Residents must also meet eligibility requirements in order for the payment reform model to be applied. CMS defines eligible residents as those who have resided in the participating facility for 101 cumulative days or more, are enrolled in Medicare, Part A and Part B fee-for-service and Medicaid, or Medicare, Part A and Part B fee-for-service only, have not opted out of participating in this initiative, reside in a Medicare or Medicaid certified long-term care facility bed, are not enrolled in a Medicare managed care plan such as Medicare Advantage, and have not elected Medicare hospice. CMS states that these 6 conditions, pneumonia, urinary tract infection, congestive heart failure, dehydration, COPD or asthma, and skin infections, are linked to approximately 80% of potentially avoidable hospitalizations among nursing facility residents nationally. If one of the 6 conditions is suspected, an eligible practitioner must confirm the qualifying diagnosis through an in-person evaluation or qualifying telemedicine assessment. This needs to be done by the end of the 2nd day after the acute change in condition. The evaluation must be documented in the resident's medical record. The new code can be billed even if the exam reveals that the resident does not have one of the 6 qualifying conditions. The qualifying diagnosis for pneumonia is a chest X-ray confirmation of a new pulmonary infiltrate or 2 or more of fever greater than 100 degrees Fahrenheit or 2 degrees above baseline, blood oxygen saturation level of less than 92% on room air or unusual O2 settings in patients with chronic oxygen requirements, a respiratory rate above 24 breaths per minute, or evidence of focal pulmonary consolidation on exam, including rales, bronchi, decreased breath sounds, or dullness to percussion. The qualifying diagnosis for congestive heart failure is a chest X-ray confirmation of a new pulmonary congestion or 2 or more of the following: blood oxygen saturation level below 92% on room air or unusual O2 settings in patients with chronic oxygen requirements, new or worsening pulmonary rales, new or worsening edema, new or increased jugulovenous distension, or a BNP of greater than 300. To qualify a diagnosis for COPD or asthma, there must be a known diagnosis of COPD or asthma or a CXR showing COPD with hyperinflated lungs and no infiltrates, and 2 or more of the following: symptoms of wheezing, shortness of breath, or increased sputum production, a blood oxygen saturation level below 92% on room air or unusual O2 settings in patients with chronic oxygen requirements, acute reduction in peak flow or FEV1 on spirometry, and respiratory rate of greater than 24 breaths per minute. The qualifying diagnosis for skin infection is the new onset of painful, warm, or swollen indurated skin infection requiring oral or parenteral antibiotic therapy. If associated with a skin ulcer or wound, there is an acute change in condition with signs of infection such as purulence, exudate, fever, new onset of pain, or induration. To confirm a diagnosis of fluid or electrolyte disorder or dehydration, the resident must display an acute change in condition and 2 or more of the following: a reduced urine output in 24 hours or reduced oral intake by approximately 25% or more of average intake for 3 consecutive days, a new onset of systolic blood pressure less than 100, sitting or standing, 20% increase in blood urea nitrogen, or 20% increase in serum creatinine, a sodium of greater than 145 or less than 135, or orthostatic drop in systolic blood pressure of 20 or more going from supine to sitting or standing. A qualifying diagnosis for a UTI is dependent upon 100,000 or more colonies of bacteria growing in the urine with no more than 2 species of microorganisms and 2 or more of the following: a fever of greater than 100 degrees Fahrenheit or 2 degrees above baseline, peripheral white blood cell count of greater than 14,000, or symptoms of dysuria, new or increased urinary frequency, new or increased urinary incontinence, altered mental status, gross hematuria, or symptoms of dysuria, new or increased urinary frequency, new or increased urinary incontinence, altered mental status, gross hematuria, or acute costovertebral angle pain or tenderness. The introduction of the payment reform model in ATOP 2 is meant to create incentive for practitioners to treat nursing facility residents in the facility rather than transfer them to a hospital. The payment model will equalize payment for an acute change of condition visit, regardless of location of services provided. Practitioners can expect to receive an additional $70 per beneficiary when using this new billing code. This code may only be applied for the first visit in response to a beneficiary who has experienced an acute change in condition to confirm or treat a diagnosis. In order to build this additional revenue, a new code has been added for participating practitioners. As this table demonstrates, the new acute nursing facility care CPT code reimbursement is equivalent to the current hospital visit CPT code. NPs and PAs will be reimbursed at 85% of physicians. The code may be billed only once for a single beneficiary, even if the beneficiary has more than one of the 6 conditions. The practitioner may bill the new code even if upon examination it turns out a beneficiary does not have one of the 6 conditions. And CMS intends to waive any requirement for a 20% beneficiary coinsurance or payment of deductible. If, after the nursing facility's maximum benefit period, it is suspected that the beneficiary continues to meet the qualifying criteria, a new practitioner assessment is required. And finally, subsequent visits would be billable at current rates using existing codes. The process for determining billing practices with this new code is very straightforward. If a resident is appropriately managed in facility per CMS guidelines and experiences a suspected qualifying acute change in condition, an in-person evaluation completed by an eligible practitioner within 48 hours of the acute change in condition may be completed. A qualifying telemedicine assessment may be completed in lieu of an in-person evaluation. If the resident meets the beneficiary eligibility criteria put forth by CMS, the new billing codes may be applied. According to CMS, the following activities should occur for the consultation to qualify for the practitioner confirmation criterion for this component of the payment model: an RN assessment qualifying a change in condition. The RN and practitioner should discuss the resident's change in condition to determine if a telemedicine consultation is warranted. The requirements would be similar to the requirements for CMS billing codes 99306 to 99310. A full H&P and describing that the consultation was completed using telemedicine, why an in-person visit was not feasible, and confirmation that the beneficiary's condition meets the criteria for reimbursement under this initiative. Telemedicine consultations should occur during off hours and when there is no available practitioner on site. The documentation of the H&P needs to be transmitted and filed in the resident's chart. According to CMS, telemedicine systems should be able to provide utilization information such as a date and time stamp and duration of consultation, information on the clinicians and practitioners involved in the consultation and which long-term care facility the event occurred in, information about the beneficiary who received the consultation in compliance with applicable privacy requirements, and preferred, aggregated reporting capabilities such as total consults in a given time frame or long-term care facility, or by practitioner, day of week, or time of day. For information on technology, hardware, and software requirements, visit atop2.org. The second practitioner payment included in the payment model is for care coordination. The purpose of this payment is to create an incentive for practitioners to participate in nursing facility care conferences and engage in care coordination discussions with beneficiaries, their caregivers, and the long-term care facility interdisciplinary staff. The payment for a nursing facility conference is $77.64. The base amount is subject to geographical adjustment. NPs and PAs are reimbursed at 85% of physicians. Care coordination needs to involve the practitioner, resident, family or other legal representative, and one member of the nursing facility interdisciplinary team. The conference must last at least 25 minutes and must not include a clinical examination during the discussion. Finally, the discussions must be documented in the resident's medical chart. The care coordination discussion may include the review of history and current health status, typical prognosis for beneficiaries with similar conditions, the resident's daily routine, measurable goals agreed to by all, necessary interventions to address risk for hospitalization, a discussion of preventive services available in-house, development or updating of person-centered care plan, discussion of potential discharge to the community, or establishment of healthcare proxy. The Care Coordination Billing Code can be billed once per year in the absence of a changing condition. The code can be billed within 14 days of significant change in condition that increases likelihood of hospital admission. If billed, the change in condition must be documented in the beneficiary's chart and reflected in the comprehensive MDS assessment. CMS intends to waive any requirement for a 20% beneficiary coinsurance or payment of a deductible under this model. And finally, the code can be billed for beneficiaries in the target population when they are on a covered Medicare Part A SNF stay, as long as the requirements listed above are met. For questions regarding ATOP 2 and payment reform for practitioners, email Adriana Mahoney at amahoney@healthinsight.org or call 775-530-4215.